My name is Amy Fryer, and I am the Inclusion, Diversity, Equity, and Accessibility Lead for the Health Data Research Network. My academic background is in human rights and media studies, which I now bring to the critical realm of administrative data curation and idea-informed data research design. I'm also a person with a disability, which doubly informs my relationship to the space of idea. So before we get started, our guests, Hilary and Yona, who I will introduce momentarily, have asked me to spend a few minutes talking about HDRN's approach to accessibility. So I thought I would do this by addressing why HDRN chose to move forward with the IDEA acronym rather than other popular expressions of IDEA, EDIA, EDII, or JEDI, etc. So as we have seen over the past decade, there has been really an expansion of EDI terms and initiatives. And in part, this speaks to the proliferation of the wide use of equity, inclusion, and accessibility concepts and the need for specific adaptation in local contexts. In other ways, the changing landscape of equity concepts and movements towards the inclusion of accessibility within these spaces demonstrates a real shift in need and urgency towards disability inclusion. From my perspective, we're really just beginning to have the conversation about what real inclusion of disabled people within academic institutions and research programs. And we have really a long way to go in this respect. The academic value on intellect has often worked to exclude people with cognitive and speech conditions. And this also holds true for people with physical disabilities, which sits in tension with the academic standards and working conditions. There really hasn't been a true reckoning with the metrics that are used to evaluate academic contributions that add value to academic communities beyond narrow things like publications and grants. This includes a whole host of other contributions that would make a path for disability inclusion in academic spaces. Next slide. So for HDRN, IDEA is just one frame to help us think through the oppression and biases in data systems and the research environments and infrastructure that we are really creating in this space. We have found this frame helpful not only because it directly attunes us to accessibility, but also because it reorients us away from the traditional hiring and HR metrics associated with equity, diversity, and inclusion in its traditional forms towards real practical implementation and embedding, operationalizing these concepts in the systems and data infrastructure that we're really enabling within HDRN. Including accessibility really ensures that we are purposefully including disabled researchers and community members and decision makers and creating spaces where diverse voices can substantively be heard. Next slide. So I'll just note really quickly here that when we first started with IDEA at HDRN, we did a quick scan of our member organizations to see how they defined and applied accessibility. Only 2 of these organizations had working definitions for accessibility, and both narrowly defined the social and political frame of access and intersectionality connected to this concept. So over 2022, we worked together to define what accessibility meant for us, culminating in this definition. So for us, accessibility refers to the design of products, devices, services, or environments for people who experience disabilities, as well as the continuous commitment to the removal of political, social, economic, historical, and systemic inequities that limit full experience in social space and life. To fully address accessibility, we must commit to addressing systemic ableism, oppression, and historic inequities encoded in policies, practices, and services. Next slide. We aim to practice accessibility in a number of ways, not limited to really working to understand individuals' accessibility needs and recognizing that needs may change. This is especially true considering that we understand that someone can become disabled at any point in their life. So access needs may change at any point. We work to provide confidentiality We want to ensure that technology and formats meet people's needs, and we commit to using little to no jargon or acronyms. Next slide. So finally, we try to take a holistic approach to disability and accessibility within the data research environments and infrastructure we are building, recognizing that there is a range of visible, invisible, and emerging accessibility needs amongst us. So I hope that this quick introduction provides a peek into HDRN's approach to accessibility. And I know that our guest today will talk more about working with disability communities in their research programs and as research subjects, which provides a whole other layer to what disability inclusion means within research spaces. So with that, I'm pleased to introduce Hilary Brown and Yona Lenski. Dr. Hilary Brown is an associate professor in the University of Toronto in the Department of Health and Society and the Dalla School of Public Health. She is cross-appointed to the Temerty Faculty of Medicine's Department of Psychiatry and is an adjunct scientist at Women's College Hospital and ICES. Dr. Brown holds a Tier 2 Canada Research Chair in Disability and Reproductive Health. And Dr. Yona Lenski is director of the Azriel Adult Neurodevelopmental Center and a senior scientist in the Campbell Family Medicine Health Research Institute at the Center for Addictions and Mental Health. She also directs the Healthcare Access Research and Developmental Disabilities Program at CAMH, is a professor in the Department of Psychiatry at the Temerty Faculty of Medicine at the University of Toronto, and adjunct scientist at ICES. So with that, I'm very pleased to hand it over to Hilary and Yona.
Thank you so much for the introduction, Amy, and for starting us off with such an important discussion. I'll just go ahead and share my screen. Okay. So thank you again for the invitation to join you today. We're really looking forward to being able to discuss inclusion of disability and accessibility considerations in administrative health data research. So we have a couple of objectives for our talk today. We really want to approach this conversation from a couple of different perspectives. First, I'll start off by talking about how to include measures of disability in administrative health data research, including what we currently have available to us and what we really should be looking forward to including in the future. And then Yona will discuss accessibility considerations from study planning to knowledge dissemination, including how to make our research teams more inclusive of people with disabilities. And then we'll also finish off with some personal reflections on things that we've learned over the years in doing this work. So starting off by looking at measurement of disability in health administrative data. Disability is quite frequent in the population, with about 20 to 24% of the population experiencing a physical disability impacting mobility, a sensory disability impacting vision or hearing, or an intellectual or developmental disability impacting cognition and adaptive skills. So disability is very common. It's considered to be the most common minority population, and yet it is also often excluded from research conversations about health equity and population health. And so what we'll argue today is that inclusion and measurement of disability is really critical in population-based research. To start thinking about how we can measure disability in health administrative data, I think it's important to understand some of the models that we have for understanding disability. There are quite a few models, but I'm just going to highlight two that are probably the most frequently used. The first is a medical model of disability, which is sort of a historical way of viewing disability that tended to view disability as a medical problem or illness to be treated or prevented. This model of disability tends to focus on impairments. So for example, impairment in terms of health or well-being, and it's widely criticized for viewing disability as pathological. So what is more common now is to use more of a social model of disability, which recognizes that disability is independent from health and is actually a result of environmental factors. So, for example, structural factors that might limit participation in society. So one way of thinking about this is the idea that if someone uses a wheelchair, their disability is really enacted in the way that the built environment may be around them. So for example, lack of elevators, lifts, ramps, etc. And so it really is an interaction between the individual and their environment that creates disability. The social model of disability does recognize that people with disabilities may experience disparities in health and mortality, but what's really key to this model of disability is that this recognizes that these disparities are driven by these structural barriers. So the reason why I mention this is because, of course, with administrative data, we are limited in terms of what we have access to in the data sets that we have, because the data were often collected for other purposes. So, for example, planning of healthcare systems. And so when we think about the algorithms that we have available to us currently to look at disability and administrative data, we are somewhat constrained by the data fields that are available. And Yona's done some really interesting work in relation to intellectual and developmental disabilities, showing how our reliance on health administrative data only may significantly underreport the prevalence of intellectual and developmental disabilities in the population. So Yona's team used health administrative data from ICES in Ontario and looked at the prevalence of intellectual and developmental disabilities in adults using health administrative data only, social services data only from the Ontario Disability Support Program, and then both sources of data. And as you can see in the Venn diagram on this screen, if we use only health administrative data, we actually only capture about 2/3 of individuals with IDD in the population. So again, just highlighting how relying on diagnoses and indicators of impairment may significantly underestimate the prevalence of disability in the population. Measurement of physical and sensory disabilities is also quite challenging based on the information that we currently have in health administrative data. There are algorithms that use diagnostic codes to identify musculoskeletal disorders, neurological disorders, permanent injuries, and congenital anomalies. And sometimes the diagnoses that are included in these algorithms can be paired with measures of assistive device use if other sorts of data sets with that information are available. Now, the algorithms that we currently use in our research that includes physical and sensory disability have been validated by prior teams showing that these categories are at least correlated with self-reported measures of functional limitations as well as need for accommodation when accessing care. However, they do still have a number of limitations, which I'll mention in just a moment. Likewise, there are algorithms for identifying diagnoses associated with blindness or low vision, as well as deafness and hearing impairment. But again, they do have their limitations. So these are algorithms that have been specifically developed to identify disability, but you might be wondering, what about other measures of comorbidity that you might be more familiar with? So for example, the Charlson Comorbidity Index or the Elix-Hauser Index. These are indices that use healthcare utilization patterns to reflect different severities associated with morbidity. But it's important to recognize that these healthcare patterns don't clearly or consistently reflect disability specifically. And this relates to a really important idea that again goes back to the social model of disability, that disability and health are distinct constructs. And an issue with conflation of disability and illness is that it does falsely presuppose that people with disabilities cannot or are not healthy. And with this conflation, it prevents public health attention to the health disparities that are experienced by people with compared to without disabilities. So it's really important to keep these concepts of disability and health separate. A recent policy shift in the United States really reflects the importance of this concept. So I believe it was within the last couple of weeks, the U.S. National Institutes of Health designated people with disabilities as a population with health disparities. And this is a really, really important movement forward in health research in the United States because it not only recognizes inequities experienced by people with disabilities and the importance of addressing them, but also opens up new funding opportunities and pathways to supporting research in this area. So again, just reflecting the importance of examining health equity in people with disabilities. I'm just going to quickly give a couple of examples of how our teams have applied disability-related algorithms in our own research with ICS data in Ontario. Iona's team has done some really important research during the pandemic showing health disparities in people with disabilities, intellectual and developmental disabilities, in relation to rates of hospitalization, admission to intensive care unit, and mortality following COVID diagnoses. Again, a really important application of these algorithms that gives us important health equity information to be able to plan policies around COVID response that without population-wide data may not have been possible. Likewise, our teams have done some important research on pregnancy in people with disabilities. So for example, severe maternal morbidity and mortality are key indicators of maternal health in the population that are monitored both nationally and internationally as indicators of whether high quality pregnancy care is being delivered. And we've shown important disparities in this outcome in people with disabilities. Again, without the measurement of disability and health administrative data, these sorts of disparities wouldn't be able to be identified. And just as a final example, we've also used these algorithms to look at other outcomes like experiences of violence during pregnancy in people with and without disabilities. So I did mention that there are some limitations to these algorithms. So for example, not all diagnoses allow for inferences about functional limitations. So for example, with a condition like quadriplegia, one might be able to imagine sort of the impact that might have on an individual's life. Whereas something like multiple sclerosis, there's very clearly a large range in terms of the severity and manifestation of an individual's symptoms and whether they find them disabling. Likewise, not all individuals with disabilities have a diagnosis. A good example of this is chronic pain can often be very difficult for someone to get a diagnosis. So this sort of disability would not be captured in health administrative data. We also know that disabilities tend to be underreported in health administrative data because the focus of most health records and healthcare encounters is on acute problems. So for example, there's been some research from the US showing that just over half of people with quadriplegia and multiple sclerosis had diagnostic codes for these conditions in the year after diagnosis, showing that their healthcare tended to focus on other things. And then, of course, we all know that diagnostic codes can be limited in their accuracy and completeness. And so what can we do to improve the measurement of disability and health administrative data? I think we really need to move beyond just being able to capture diagnoses. There are ways of measuring self-reported disability that have been used in routine reporting in home care and rehabilitation services in several countries that could be useful. But more importantly, I think self-reported measures of disability as one of several equity-related variables. So for example, along with race and ethnicity and gender identity, I think is really going to be important for inclusion in health records and therefore health administrative data. And I'll just flag that Dr. Andrew Pinto at St. Michael's Hospital in Toronto is doing some really interesting work in this area. But until we have that sort of data, I think there's a few things that we can keep in mind to try to do this sort of research as best as we can. One is to make sure that we include linkage of records across time to ensure that disability can be identified in multiple years. So for example, to capture diagnoses made in childhood if an individual did not seek care for their disability specifically after that time. Another important improvement is being able to link health administrative data with other sources of information. So for example, disability-related support records like in Iona's work that might better reflect participation restrictions. Of course, this still only captures people who are receiving those services. Linkage of health administrative data with other forms of data. So for example, the census or surveys that might include disability measures is also critical. And there's also been some really interesting work being done using machine learning to try to better classify disabilities using existing data. So that's just a few thoughts around the measurement of disability in administrative data, and I'll hand it over to Yona to talk about accessibility considerations.
Thanks so much, Hilary. Yeah, if we go to the next slide, two main challenges. Well, this is the one I'm going to talk about the most. And really, it's a challenge for all of us to think about how we can help health services researchers make accommodations in the research that they do so that their work is fully accessible. So if we go to the next slide, there's two visuals here that I'll explain. And it's sort of playing with this idea of kind of who is seen and how we support people and how they're seen. So the first image, it says we don't see them, and we is kind of emphasized. And it's a photo of some men, in this case, from an institution that closed here in Ontario. And it highlights that for some disabilities, certainly the one that I studied the most, those are developmental disabilities. In healthcare, we literally didn't count this group because we actually didn't see them because they weren't in our main healthcare system, they were somewhere else. And there still are examples of disabled people sort of being outside of the system and not being seen because they're literally not included. But there's another kind of invisibility, I think, that happens a lot in Canada, in healthcare, and how we collect our data and report on our data. So here I have the same words, we don't see them, but now I'm emphasizing the word see. And I have an image of a number of dogs together with a fox, and they're all facing the same direction, and their coloring is quite similar. And if you don't look closely, you may not notice that there's a fox in the midst of all these dogs. And I think when we think about disability, if we don't decide it's something that we should be measuring or looking for or paying attention to, either in how we deliver our healthcare or in how we study it, then we're not going to make those unique concerns or issues known. We're not going to think about them. And there's a lot of harms, I think, that come with that. So if we go to the next slide, the slide says relationship building, it matters. And there's an image here of myself and my colleague from Surrey Place meeting with some individuals with developmental disabilities to talk about some of the research that we were doing, actually that Hilary was showing in some of the slides, where we were looking at healthcare issues for people with developmental disabilities. And I chose this picture because we look like we're smiling, we look like we're having a good time. There's no big reports in front of us. I think we did have a few slides, but it was really trying to capture that when you do work that matters to people about their health, even if your research is on administrative data, it's this obligation to build trusting relationships with people for whom the research makes a difference. And that those kinds of relationships, I think, take time and have to be done in spaces where people are comfortable. So in this case, the people in the photo actually work at that organization, and this is a very comfortable place for them to be and to have a conversation about data that are kind of complicated and potentially upsetting, to think about and unpack what that means for them. So relationship building, I think, regardless of the kind of research we do, is probably the most important thing to think about. Next slide. So there's a really important mantra that comes from the disability community: nothing about us without us. And I'm just going to walk through how we think about that, or how I try to apply it with my own thinking in the research that I do. So looking at study planning, and this could be, again, an administrative health data study, there's still a lot of things you want to think about when it comes to disability. If you're going to be working with people who have disabilities on your research team or in an advisory. So thinking about how are you going to be having meetings with these individuals over the course of the study as you're planning kind of what makes sense for them, what resonates. Should it be in person? Is it actually easier or more accessible for them to be virtual? If you do something in a hybrid way, how's that going to work out? Thinking about tokenism in this very easy way that we can say, oh, we included a disabled person in our study, you know, but really, what does that mean? How are they involved? How is it meaningful? And thinking as well about not just having one person having to play that role, representing an entire, very diverse community, and the importance of the power people have when there's many people doing that same work. Thinking about if it makes sense to have a lot of people in one big meeting and having all your knowledge users come together, or if it makes more sense to build trust and have smaller groups for some of those meetings. And I'm just thinking about one project that Hilary and I were both involved in, actually, where we thought it was really good at the beginning to bring everyone together. And we thought we'd explain things in a way that, you know, everyone could understand and relate to. But I think we weren't as sensitive as we could have been to some of those power differentials and the fact that we didn't all have that same sense of belonging, of relationships. So even though everyone was there, there were still a lot of things I think we had to consider. And it was important for us to have a couple of smaller group discussions at that early point, I think, to kind of strengthen how everyone could work together. Thinking about the materials you have for the meetings, if you're going to be including someone with a disability, what's the format of the materials? How do we help people find that information? In the work that I do, working with people who have developmental disabilities, it's not just how we send things out in advance or the format they're in, but we actually have someone hired on our projects now who's really there to support that person. Because if we think about accommodations, some people need accommodations to see or to hear things, or they need accommodations, in terms of mobility. But some people need accommodations just to help them kind of follow along, know how to ask a little question while a meeting is happening, help them feel like they can speak up, or maybe speak on behalf of that person if they don't feel like they can. So having someone whose job it is really just to take care and support that person to be as present as they can be is really important. As leaders in the work, if you're inviting disabled people into your space, please do some homework and know about what some of those perspectives might be. What are the sort of hot topics or issues? What might be some concerns? How can you do your own learning so that you don't start things off in a way that make them feel like either hurt by things that are being said, or left out of the situation, or really sort of setting things up in a way that doesn't lead to success. So language really matters. I think I try to work, I think no matter how I try to be honest, sometimes I certainly make mistakes with language, and a word that's really important for one person can be a word that hurts for another person. So we can't always get it right. So relationships and trust, I think, is really important, but giving some time to think about what some of those sensitivities might be and coming up with a plan of how you can explain that's really important. And also keeping in mind that people should be valued for the work that they do in your team. So really thinking about how you're going to pay or support people for that work, and recognizing the time it takes, not just to be at that meeting, but for some people, that preparation it takes to get to that meeting, whether it's, having to wait a really long time for Wheel-Trans, which is our sort of accessible transportation here in Toronto, or just about having to get an attendant or someone to support you, to organize certain things, to think about what you're eating that day, to know about what's going on in terms of accessibility of washrooms if you're doing something in person, and also that time after. So I remember in one project, not realizing it myself, how long it took for one of the individuals who had a disability to kind of decompress and rest and recover. So my meeting might take 2 hours, but it might take them a day and a half in terms of preparation and the work that happens after. So next slide. Nothing about us without us also applies to, we're looking at our administrative data, we're noticing an interesting pattern, we're interpreting it, we're getting ready to write something. So I've got 2 images here of a study that really was very important. Hilary shared some of our results around mortality for people with disabilities during the pandemic. And this study came out, it was a big deal because it was the first study that looked at, it was in the BMJ, and the heading for the study says risk prediction of COVID-related death and hospital admission in adults after COVID vaccination. And it was looking at everyone in the UK and how they did. And one of the highlights of the study, and then what got interpreted from the study, had to do with this one group of individuals, people with Down syndrome, facing the highest risk from COVID even after they were vaccinated. So when it came to interpreting the data for this study, the people who wrote the study were not experts in Down syndrome. And I don't think they really consulted with people who had Down syndrome to think about what those findings meant or would mean to them. And this was a group of people who were fighting so hard to try to get vaccinated because they knew their mortality rates were higher. And then the study comes out with these headlines that made the news, highlighting that actually, even with vaccines, there's still terrible risk for mortality. And that was a terrifying finding that actually wasn't really fully supported in the data. So I was part of a group that did a rapid response to that study because of how upset people were, trying to highlight what those data really meant for this population. And I think had this group maybe thought about how to include people that these data would impact and what it might mean to them when they see a really scary headline like this, it would have made a difference in terms of thinking about the data and what they mean, and also that really stressful, traumatic experience that they didn't need to have. So if we go to the next slide. So nothing about us without us also applies to our implications of our study and the crafting that we do of the recommendations that we make. So I put down a couple of bullets with questions that I sort of try to think about. One is, what do we say about what the findings mean and what needs to happen next? So we know generally what our findings are tell us, but what is it that we're going to say about it so that those things in the example I just gave you don't necessarily happen? And this is something that I think we can really work with people who are, impacted by the study, if the study includes people who have disabilities. So what is it that we're going to say about it? And what are the implications of what it is that we do say? So if we're talking about, for example, one group, maybe a group of people with disabilities who are at a higher risk of having something happen than another group, but the overall likelihood of that thing happening is fairly low. How do we say that, right? Because we can say relative risk super high. Oh my gosh, watch out, this is terrible. Or we can say it doesn't really happen very often, but if it does happen and it's rare, it's much more frequent. And the way we make that message has really important implications to a group of people who've been marginalized, who are harmed, and who sometimes, I think, because of our ableist attitudes, are not able to live in the same ways as other people. So we have to think about these things, and it does take time to do it. So even before you write up your paper or your report, having those relationships and being willing to take the extra time. Like, I know this happens to me. I'm so excited about my finding. I want to get it out fast. But if I don't think about these things and how it impacts the group, I might not say it right. And the ramifications that sometimes are a little bit tricky to undo. So I think if you're really going to partner in this kind of work, where you're trying to think about how you would share information or what results actually mean to a population, that you are gifted with being able to use administrative data to study them. You need to be able to be flexible, and you need to be able to be open to maybe what your main idea was that you thought you would express in terms of what the study means or what to do with it. There's no point in asking people if you can't really be open to potentially changing a little bit of your own perspective. So thinking about the words that are used, which priority goes first, and sensitivity to some of those nuances is really important. In an example of a meeting that we just recently had, Hilary and I, and we'd asked some of the folks who were disabled in our meeting about this, we had this idea of how we were going to present our results. And we were thinking, let's go from the individual to sort of the broader group of providers in the system to the entire system. So sort of going from the small to the big. We thought, well, that makes good sense. We'll make our recommendations go in that way. But the disabled people in our research group were saying, you know what? Could you flip it around and start the other way? Because when we go first, it's kind of suggesting that it's all up to us, that we have to fix things or change things. And actually, it's not. There are major systemic barriers going on here. Can that please go first? So we were doing something that we thought made sense and sounded good. We wouldn't have thought of that ourselves. We didn't think of that ourselves, but it made perfect sense. And it didn't really matter that much that we'd switched the order to the findings. But now suddenly we were giving a message that we wouldn't have been able to think about as non-disabled people, I think, had we not had that conversation. Next slide. So this is just an example. It's a visual of a report that we did through ICES, looking at the health issues experienced by people with developmental disabilities. And what I want to highlight in this visual here of this report is that with every recommendation that we made up, we made sure that we spoke to people with developmental disabilities to find out what that recommendation actually meant to them. So we met with them, we shared the data, we took the time, we got quotes from them about what would be important, and we kind of balanced that visually. We said it's really important for people to see when they see this recommendation, this is why that recommendation is there, or this is what this means to one individual. Next slide. So we're at the point now of sharing our information. So nothing about us without us dissemination. We have to think about how accessible the information is that we share. And again, accessibility is different for different groups, and I'll show a few examples. We have to find ways to share also the sharing. So if I want something to reach the disability communities, and there's many communities within the disability community, working with them to see how to give them what they need so that they can also share that information is really important. And again, this very last step also takes time. And so thinking again, are we always in a hurry? Does it have to be in a hurry? On the one hand, yes, the study's coming out, this is the day, it's got to be ready, we're just going to do it, and then we'll follow up after. Sometimes that happens. But if you're doing a study where you're saying something again about people in the disabled community, and you haven't made that information accessible yet to everyone in that community, what does that say about how important that finding is for them? So sometimes I think there may be a hurry, but sometimes I would say if we do our homework, have these relationships, think about it, It's even better if when we release or share our information, we found those ways to share the sharing, and we have people able to do that work as an accessible a way as possible. Next slide. So this is just an example of using alt text in our social media. So I'm showing a visual here that ICS posted of a talk that, or a day that they had actually last May on advancing health equity through data. And then you see a little black box at the bottom of the screen that says alt. And then if you click on it, you can find out what the image description is. So it says 2023 ICS Research Forum, Way Forward Advancing Health Equity Through Data. So it says the same thing as the picture. So why does this matter? It matters because if you can't see that picture, you've missed that entire joke or that entire bit of information. The other reason why it matters, besides the fact that if you're using a screen reader, it will read that alt text out loud to you so you don't have to see it. It also, to me, is a signpost. It says, we're hosting this event on health equity, and we want to make sure that everybody knows we're hosting this event, because health equity includes people who have disabilities, including people who can't necessarily see this visual. So by putting alt text every time you make a social media post, you're saying this matters to everybody, and I'm trying to make my work accessible because I've made that consideration. Next slide. There are other ways we can make our research meaningful as well. So as I said, I work with people with developmental disabilities. And so sometimes I think about what it is if they can't see the information, how I would give it to them. But I also think about how they could understand the information in a different way for that disability. And so this is an example of an administrative health data study that was looking at depression in people who were in Special Olympics and who are not in Special Olympics. And what we did, and we try to do this with all of our studies, is we make these easy read summaries of the information so that when the study comes out, you can read the full article, which is kind of complicated, or you can read the easy read. And easy reads have photos in them, and they have less words. And we've made sure in the work that we do that we work with people with disabilities to figure out what words would make sense for the concepts we want to share. And the other image that is on this slide is actually of a podcast where we had people with developmental disabilities interviewing the lead researcher on the study, Dr. Megan Lloyd, to talk about what that study meant to her and also what it could mean to them as people trying to unpack or understand that information. So there's a lot of ways we can make our research meaningful. Next slide. Which research do we make meaningful? I love this idea. It has the University of Toronto on it, but I should have caught that error. There's a little logo at the bottom. This is actually work that's being done from the University of Glasgow, where they said research should be available to everyone. And it doesn't just have to be the research on people with disabilities. So they met with a group of people with learning disabilities, or what we call intellectual or developmental disabilities here. And they said, let's pick some studies that are important and find ways to translate them. And so they translated, actually it was I think it was like a systematic review on cancer and mental health. And they tried to translate the findings from that study in an easy way so that people who had developmental disabilities or other kinds of learning issues could still understand the study. And then they also chose a study about soccer and the association with brain disease and a way to kind of simplify that. So all of our research, regardless of whether it's about people with disabilities or not, should be available to everyone. And we need to be thinking about accessibility across disabilities when we do that. Next slide. So I wanted to make one last point, and then I'm going to give things back to Hilary. When we do this work around, helping health services researchers to make their work more accessible to the people they're working with, we also have to keep in mind that we're really making accommodations so that all health services researchers can participate in research, because we want everyone, regardless of whether they have a disability or not, to be able to join the research enterprise. And that's not just as an advisor or a person with a disability, it's as a scientist or a research staff or a trainee. So these accommodations make sense for everybody that we work with and not just the people that we study. Next slide. It's really important to learn to be an ally. It's a constant thing. I'm still learning. I get a lot of things wrong, but I think it's an investment that all of us should be doing. I think if we want to really support the disability community. So my last slide is a nice visual of a beautiful article that was actually written about healthcare for autistic people. And it was written by 3 autistic healthcare providers. And it's this model called SPACE. And I think it applies not just to when we give our healthcare to people with disabilities, but also in the environments where we work in healthcare. And it just reminds us that we need to give people space, and thinking about the sensory space, that sense of predictability in the spaces they're going to be in, that acceptance of who different people are and what they bring to the table, how we do our communication, and the importance of empathy. So it's specific to autistic people, but I think we can broaden it to disability more broadly, and I would invite people to read that paper. And I'm going to give things back to Hilary.
Great, thanks so much, Yona. So we'll open it up for questions in just a moment, but we wanted to finish with a few reflections from our own work with working in community engaged research with populations with disabilities. And these reflections that I'm going to provide are ones that one of our peer researchers who works on our work related to disability and pregnancy, she and I came up with these together for a talk we recently did for ICES. So, and these sort of reflect lessons that we've learned together from the process of working together. So we've sort of reflected on this idea that numbers can be unintentionally used to stigmatize and medicalize. And I think the BMJ study that Yona mentioned earlier is a really good example of that, where, you know, there was no malintent from the researchers, but the way the study findings were framed were really quite shocking and distressing to populations. And so we need to think about that in relation to how we frame our findings and also in relation to how we use them. So being really clear about the need to call for changes in medical care, for example. Sometimes language can be such a simple thing, but also complicated at the same time. So when we started doing our research on disability and pregnancy, we used language like poor perinatal outcomes, and that was shown by our advisors to feel like that was putting the onus on them or creating sort of a negative stereotype of their experiences. So we talked about using more neutral language like perinatal complications. Likewise, we had some language around when people initiated pregnancy care, and our advisors talked to us about how that made it feel like, again, the onus was on them in terms of accessing the healthcare system, when in fact, a lot of the barriers they experience are structural in nature. So we talked about language of receiving perinatal care instead. So some really sort of practical things to think about. Yona already mentioned this idea of tokenism, but I'll just reiterate that when we engage with communities, we want to make sure that what we do is really meaningful and recognized in tangible ways. So for example, co-leadership and not just participation. So co-presenting and co-writing papers can become a really important way of engaging. And also recognizing that an intersectional approach is important because people come from different communities that experience different outcomes. I'll just very briefly mention some process challenges that we've sort of identified and tried to change the way we do things over time. And I think this is true for a lot of community engaged research. So when you're writing your grant, for example, make sure that you're budgeting for engagement with communities so that you can give people good funding for their time, good honoraria for their time. One thing that I've learned over the years is over budget for that, because often existing advisory committee members will recommend new advisory committee members, and you want to make sure that you have the funding to grow your advisory committee as people recommend it. There's often structural barriers within academia to engaging with communities. I can give lots of examples of that, but sometimes it's just things like processes for hiring casual staff. What's adequate compensation? What if training requirements are inaccessible? And so sometimes we need to push back against those structural barriers to engaging with communities. Likewise, making sure that if you do engage with peer researchers, that they're getting the supports that they need. And I think all of this means taking the time as researchers to build relationships. So for example, it's not just about quarterly meetings with an advisory committee, it's about sitting down and having a coffee and getting to know people. So in terms of a couple of very brief recommendations, when we're doing this kind of work, we want to make sure that we start early and think longitudinally. We take that time to build relationships. We're flexible on the way that we build our grants for unanticipated needs. We push back against those traditional academic structures that aren't used to community engaged research. We make sure that with the groups that we work with, we agree on commitments and ways of acknowledging them, make sure that there's opportunities to lead. We make sure that we ourselves are responsive to community input. So again, not just going through the motions. And then finally, again, remembering to think about intersectionality and to learn and grow accordingly. So I want to make sure that we have enough time for discussion. Yona and I put together a couple of reflection questions for all of you to think about in terms of where accessibility fits within your own equity, diversity, and inclusion plans. What are some changes you can make to your own teams and organizations to promote accessibility through your research phases? And then how can you better support inclusion of people with disabilities on your own teams as well? So I'll leave those up there for a moment, but we'd love to hear from you also if you have any questions or comments. Thanks.